Good day everyone and welcome to another screencast here in Immunology and Serology. I am your professor for today's session. I am Dr. Supachay Basit. So I hope that everyone is okay and I hope that you'll be able to learn something in today's session. So if you have any question at the end of this session, feel free to message me. For this particular lesson, we shall be discussing the mechanisms of autoimmunity, particularly on the topics of immunologic tolerance and genetic and environmental factors that may be associated to autoimmune diseases. And of course, we will also be discussing some of the most commonly encountered autoimmune diseases by the clinicians. So this includes your systemic lupus erythematosus or the SLE, rheumatoid arthritis, Granulomatosis with Polyangiitis, and other associated laboratory testing pertinent to these autoimmune diseases. And then, of course, the other type of autoimmune diseases are organ-specific autoimmune diseases. So we will be discussing several examples and associated laboratory testing. Okay, so let's start. So let's discuss first, what do we mean by autoimmune diseases? So when we speak of autoimmune diseases, diseases will involve both the humoral and cell-mediated immune response. So which means that there would be the production of antibodies, and the cells, different types of T cells, may be produced directed toward self-antigen. Self-antigen belongs to our body. It may cause tissue or organ damage in our own body. So autoimmune diseases may be classified either as systemic or organ-specific. Now, one of the most important definition or characteristics of autoimmune diseases would be the inadvertent loss of the so-called self-tolerance. Now, why self-tolerance is important? Because self-tolerance is the ability of our very strict immune system. Yes, our immune system is very strict. Okay. However, no, even if they're strict, they have the so-called leeway to accept antigen so that they will not be able to mount the immune response. However, in cases of autoimmune diseases, there would be loss of self-tolerance, okay, or the ability of our immune system to accept self-antigens is lost. Therefore, our immune system will initiate immune response against self-antigen. They will initiate immune response against our own tissue or organs. So, as you can see here in the illustration, there is what you call the mechanism of central and peripheral tolerance. Okay, so under normal, as you can see here in the illustration, so central tolerance is actually occurring in thymus and then also in the bone marrow, while peripheral tolerance occurs in the lymph nodes and in the spleen. So actually, under normal circumstances, our immune system is able to differentiate between self-antigen and non-self-antigen. If they're able to do such a thing, okay, self-antigens are actually not destroyed. But, however, as you can see here, this phenomenon is actually called self-tolerance. So, as what I've told you a while ago, when we say self-tolerance, it is actually the ability of the immune system to accept self-antigens. And if they're able to accept self-antigen, okay, they will not initiate a response against them. Okay, so the reason why there is an autoimmune disease, many immunologists thought that the reason why there is an autoimmune disease because of the ability, okay, of our immune system to tolerate self-antigen is lost. Therefore, this is what you call loss of immunologic tolerance. So, self-tolerance is actually an example of immunologic tolerance, okay? So when you say immunologic tolerance, it is defined as the state of immune unresponsiveness. Okay, so it is the state of immune unresponsiveness that is directed against a specific antigen. In this case, self-antigen. So immunologic tolerance is very important so that our immune system will not destroy self-antigen. Because when we speak of self-antigen, this pertains to antigens found, of course, in our respective organs. Okay. In order for self-tolerance to develop, okay, lymphocytes, okay, must be so-called educated, okay, so that they can distinguish between self-antigen and foreign antigen. So, the process of educating these lymphocytes actually takes place in two various levels. Okay? So, para palang pag-attend ng estudyante sa grad school, no? May undergrad and masters. But in this case, when you say central education, it happens in the primary lymphoid organs such as thymus and bone marrow. But if it's the peripheral tolerance education, it happens in the lymph nodes and in the spleen. Okay, so as you can see here in the illustration, so all these are the places where the so-called education of the lymphocytes takes place. Okay, so let me go back to the illustration. Okay, so as you can see here, in the illustration, central tolerance occurs in the primary lymphoid organs. Okay, so wait. So I'm sorry for that technical difficulty. I got confused for a while when I removed my headset. So anyway, as you can see here, in the thymus, as you can see, the T cells mature in the thymus. So as you can see, it could be a T helper cell or the cytotoxic T cells. I'm sorry for that. Okay, so as the T cells mature in the thymus, sometime in their life, they can encounter the so-called self-antigens. Okay, and these particular self-antigens are actually normally present. Okay, they are normally present on the surface of the thymic epithelial cells. Okay, so when they encounter that particular T cells, okay, that particular process is called negative selection. Okay, so in negative selections, T cells that express TCRs or T cell receptors, and these particular T cell receptors have a strong affinity for this particular type of antigens. Okay, so they have a very strong affinity for these self-antigens, and in order for them not to wreak havoc, okay, they're supposed to be deleted by apoptosis. Okay, so apoptosis is a process of the programmed cell death. Okay, so the process of negative selection can actually occur in many types of T cells. So it can occur with both the immature double positive CD4 and CD8 cells. So that's one. Cells in the cortex, okay, aside from the cells in the cortex, and also cells with the more mature single positive CD4 and CD8 positive cells in the medulla or in the medulla. So during this process, some of the reactive CD4 T cells are not deleted. So they're supposed to undergo, the cells are supposed to, as you can see here, cells are supposed to undergo negative selection. Okay, both the CD4, CD8 positive, single positive, double positive cells in the medulla or in the medulla, they're supposed to undergo negative selection. However, there is some type of T cell which is actually a T helper cell or CD4. Instead of undergoing negative selection and to undergo apoptosis, they are differentiated to Treg. Okay, so as we all know, Treg is an example of the T regulatory cells. the danger is that this particular type of Treg, okay, this particular type of Treg will actually exit out of the thymus, and once they have exited the thymus, they will now go to the peripheral lymphoid organs such as the lymph nodes and spleen. And this Treg, okay, this Treg may be reactive to self-antigen. Similarly, the same process happens in the bone marrow. In the bone marrow, so as the B cells mature in the bone marrow, okay, those with receptors having a strong affinity for self-antigens are supposed to be eliminated by apoptosis. However, some self-reactive, okay, take note of the term, self-reactive B cells are not deleted. Instead of being deleted, they are stimulated. Okay, so they are further stimulated to arrange their immunoglobulin genes. And if they are able to arrange their immunoglobulin genes, B cell receptors are no longer antigen specific. So this particular process wherein B cells rearrange their immunoglobulin genes, this particular process is called receptor editing. Okay, so that process is known as the receptor editing. Okay, B cells that possess receptors that only weakly recognize. Okay, B cells that possess receptors that only weakly recognize self-antigens are actually induced to downregulate the expression of their receptors and develop a specific state of unresponsiveness to antigen. So when they are unresponsive to antigen, so that is actually known as anergy. Okay, so that is known as the anergy. So you can see here in the central tolerance, okay, there is indeed a mechanism of our immune system to prevent destruction of self-antigen. However, as you can see, even there is in the thymus, for example, there is a negative selection process, so that cells that are reactive to self-antigens are supposed to undergo apoptosis. The same way, in the bone marrow, there are actually processes such as receptor editing, and then there's a process known as anergy that they're supposed to be unresponsive. However, some of the cell actually escape bone marrow and thymus. So that is the reason why there is a secondary protective mechanisms that will allow us to regulate cells that have escaped, okay, the thymus and the bone marrow. Okay, these cells may be destructive to our self-antigen. So that is where the peripheral tolerance will come in. Okay, in peripheral tolerance, the lymphocytes that recognize self-antigens in the secondary lymphoid organs. So when you say secondary lymphoid organs, these are the lymph nodes and the spleen. Okay, these particular cells, okay, that can actually recognize self-antigens, okay, are actually rendered incapable of reacting with those antigen. Okay, so which means that the peripheral tolerance of T cells, can result from anergy caused by the absence of the co-stimulatory signal from APC or antigen presenting cell. So in that case, there would be also binding of inhibitor receptors such as the CTLA4. So CTLA4 is actually a molecule that prevents T cell activation. Okay, so as you can see, there is a program so that there would be, as you can see here, for example, in the peripheral tolerance, inhibition by Treg or lack of co-stimulation is one mechanism. Okay, so peripheral T cell tolerance can also result from inhibition by Treg, as you can see here, and the other one is by apoptosis. Okay, on the other side, okay, self-reactive B cells in the periphery can be deleted also by apoptosis. Okay, by be rendered anergic. So pag sinabing anergic, they are incapable of being stimulated. So be rendered anergic after repeated stimulation with self-antigen, or they also receive inhibitory signal through receptors such as CD22. Okay. However, so as you can see, there are two levels. So, parang Google lang, two level of authentication. But in this case, two level of protective mechanism. So one level is central tolerance, and another level is the peripheral tolerance. So I know that for those of you who would be trying to understand the mechanism of autoimmune disease for the first time, you might actually get confused. But then again, when we say central tolerance, the mechanism involves negative selection in the thymus, so that there would be apoptosis. Okay, and then for the bone marrow, B cells are supposed to be rendered anergic, which means they are no longer capable of eliciting an immune response. However, some of the cells may still escape. So the second protective mechanism in the peripheral tolerance would involve inhibition by Tregs or lack of co-stimulation, so that they will no longer react to self-antigen, and also apoptosis. And for the other side, B cells can also undergo anergy, so that they would become unresponsive, or they can actually undergo apoptosis, so that there would be programmed cell death. So as you can see, there are two layers of protective mechanisms, so that will be preventing autoimmune disease. So the question is, how come there are still individuals who would still have autoimmune disease? Great. In some individuals, self-tolerance can fail even after this second layer of protection, even after peripheral tolerance. If this happens, autoimmunity can arise. Okay? So the development of autoimmune disease is thought to be caused by complex interactions between their many factors, such as genetic predisposition, and then exposure to environmental factors, and even defect in immune regulation, like the ones that you can see here in the illustration. Okay? So some of these factors are believed to have contributed to the presence of autoimmune diseases. Okay, so as you can see here, there are several factors that may contribute to the development of autoimmunity. So again, these are the environmental and endogenous factors that may trigger. Okay, when we speak of female hormones, do you know that women are 2.7 times more likely to acquire autoimmune disease than men? So in fact, about 78% of patients with autoimmune diseases are actually of female gender. So yes, there's a gender predisposition. Okay, so women also tend to develop autoimmunity at an earlier age. Okay, so they tend to develop autoimmunity at an earlier age and have high risk for acquiring more than one type of autoimmune disease. Can you just imagine, female, if having one autoimmune disease is bad enough, and then you'll have more than one, okay, as compared to their male counterparts. Okay, so another important fact is that females, okay, have been found to have higher absolute CD4 T cells. Remember, CD4 T cells are the one that escape the central tolerance. Okay, so which means that they have higher predisposition to have autoimmunity, and they have higher levels of circulating antibodies. So females have higher circulating antibodies as compared to men. So this observation suggests that there is a hormonal influence. Okay, so there are female hormones that may influence the development of autoimmunity. Okay, So there are several studies that shows that the effect of this particular female hormones have shown that estrogen, of course, estrogen is a female hormone, okay? Estrogen tend to direct the immune system in favor of type 2 Th2, yung T helper cells type 2 response. So, Th2, more Th2, meaning to say there are more B cell activation and antibody production. On the other hand, males that would have primarily androgens, okay, favor Th1. So, estrogen favors Th2, androgens favors Th1. Okay, so Th1 on the other hand will activate CD8 T cells. Okay, so there's another type of hormone. This is known as the prolactin. So a hormone that stimulates production of breast milk, particularly during pregnancy and nursing women. So it can stimulate. So incidentally, this particular prolactin will stimulate both humoral and cell-mediated immune response. So the stimulatory effect, therefore, of female hormones may place women at greater risk for developing autoimmune diseases. Okay, so there is another example of environmental and endogenous factors. Okay, one is tissue trauma. Okay, so when immunologic tolerance to self-antigens occur during the early development of lymphocytes in the thymus and bone marrow, some self-antigen may be cryptic. So when you say cryptic, it means it is hidden. And when you say hidden, it is not literally seen by our immune system. So they are hidden within the tissues of the host. So T and B lymphocytes are actually shielded from those sequestered antigens. And of course, since they are sequestered, T cells and B cells are not educated to become tolerant to this hidden antigen because they are cryptic. Okay. However, later in life, some of us may undergo injury or may experience inflammation or tissue trauma. So, if we experience such a thing, those cryptic antigens will eventually be exposed. So, if they are exposed, those lymphocytes who were not previously educated to the presence of these cryptic antigens because they were hidden, so these particular lymphocytes will now attack those cryptic antigen. Okay? So, this concept is known as immunologic ignorance because our lymphocytes were not educated. Okay? Because of the fact that they were hidden. Okay? Microbial infections may also trigger the development of autoimmunity. There are several instances, such as the first one is known as molecular mimicry. Okay, so mimicry refers to the fact that many bacterial or viral agents, contain antigen that closely resemble the structure or amino acid sequence of self-antigens. So they resemble the molecular structure. So one example of that is Streptococcus pyogenes. Okay, and Streptococcus pyogenes, group A Streptococcus in particular, may cause rheumatic heart fever. Okay, so that's one example of molecular mimicry. So the second way in which the microbe can trigger autoimmunity is by means of the bystander effect. Parang bystander in Tagalog, tumambay lang. Okay? So, in bystander effect, okay, the microbial organisms, unlike in molecular mimicry, do not have to share structurally similar antigens with the host. So, they do not actually share antigens, unlike Streptococcus pyogenes. However, instead, the microorganism can induce a local inflammatory response. So as we all know, if there is an inflammatory response, this particular mechanism will recruit leukocytes and stimulate the production of APC to release cytokines that are cytokines are released, and this will non-specifically activate T cells. Okay? Some of the T cells that are activated may have specificity for self-antigens, so nadamay. So kumbaga, yung self-antigens natin, nakatambay lang siya sa area where the infection has taken place. So parang nadamay siya. That's the reason why it's called bystander effect. So this expansion of the immune response to unrelated antigen is actually termed epitope spreading. Okay. Aside from that, we also have the so-called super antigen stimulation of the immune response. Okay? Super antigens are proteins. Okay? Super antigens are proteins, and these proteins are actually produced by various types of microorganisms that have the ability, so these microorganisms would have the ability to bind to both class 2 molecules and the TCRs found in the lymphocytes. So, regardless of their antigen specificity. So, one example of super antigen, I hope you could still remember Staphylococcus aureus. Staphylococcus aureus may produce enterotoxin in food poisoning. So, that's one example. And they may even cause toxic shock syndrome. Okay, so these are super antigens, okay? So what are the actions? Why do we call it super? Okay? Super antigen can act as a potent T-cell mitogens. Okay? So when we say mitogen, stimulate multiplication by activating a large number of T-cells with different antigen specificities. Now, some of these T-cells possess specificity for self-antigens. Yon, nadamay na naman ang walang kamalay-malay nating self-antigen. Okay? And if this happens, autoimmune response may result. So likewise, some viruses, aside from Staphylococcus aureus, some viruses may also act as super antigens. And example of these viruses are the Epstein-Barr virus, cytomegalovirus, and other viruses, okay, that may cause polyclonal activation of B cells. Okay, now, let's talk about the epigenetic factors. Okay, epigenetic factors and modifications of self-antigen. Okay, so epigenetic factors or epigenetics refers to modifications in gene expression that are not caused by changes in the original DNA sequence. And an example of this is the citrullination of collagen. So once the collagen has been citrullinated, it is one of the reasons for the development of the pathogenesis of rheumatoid arthritis. And then another example also as a result of this modification is the glycosylation of myelin sheath. Okay? So myelin is actually a protective sheath that covers our nerve fibers. However, if this myelin sheath is destroyed, this may result to multiple sclerosis. Okay? So these are the environmental and endogenous factors and interactions of these factors. So as you can see, the development of an autoimmune disease is a multifactorial factor. So then there would be genetically susceptible individual because there are some HLA genes, okay, that may be associated with a certain autoimmune disease, which we have discussed in adaptive immunity. And at the same time, we can also factor in the loss of immunologic tolerance. So there would be activation of self-reactive T cells and B cells and development of immune response to self-antigen. All of these factors will fall into one person, and I do not want to be gender insensitive here, but as you can see in the icon, it's female. because females are actually more at risk of getting autoimmune disease. So all of these factors, environmental and endogenous triggers, genetics, predisposition, and loss of immunologic tolerance, all of these may result to the development of an autoimmune disease. Okay, so let's talk about the different types of autoimmune diseases. So there are actually several types of autoimmune diseases. So I'll also be including supplemental PowerPoint alongside with this screencast. Okay, so there are more than 100 autoimmune diseases that were discovered, and we can divide them into systemic and organ specific. Okay, so let's talk about first, I cannot see my cursor, the systemic, and one of them is the systemic lupus erythematosus, an example of a chronic systemic inflammatory disease that may affect multiple organ system, and the most common organ that is affected herein are our kidneys. Okay, so President Marcos actually died from SLE. So here, patients develop numerous autoantibodies against certain fragments of our genetic material, such as antibodies against double-stranded DNA and other nuclear components, antibodies against lymphocytes, RBCs, and platelets. Okay, so systemic lupus erythematosus, okay, actually a disease that affects between 40 and more than 200 for every 100,000 population. So the peak age, okay, so the peak age, sorry for that, the peak age is actually between 20 and 40 years old, and female is actually women are more likely to be predisposed to SLE as compared to female. Okay, so SLE is actually due to the formation of immune complex formed. So whenever immune complex is formed, there would be complement activation, okay, chemotaxis of neutrophils, and of course inflammation. Okay, so here is an example of a patient with an SLE. So as you can see, SLE is a multi-organ autoimmune disease. So immune complex may be deposited, for example, in joints. There will be skin rashes, and one of the most predominant type of skin rashes here in SLE is actually the so-called butterfly rash. Okay, butterfly rash. Then renal involvement, neurologic symptoms, anemia, leukemia, and thrombocytopenia. Okay, so these are the laboratory tests that will allow us to diagnose SLE. So this includes CBC, urinalysis, CRP and ESR, C-reactive protein, and erythrocyte sedimentation rate. Both of these are tests to determine if inflammation has taken place. And then we can actually quantify C3 or the complement. So C3 levels can be decreased during inflammation. And of course, the most common way of evaluating whether SLE is present is by means of ANA or Anti-Nuclear Antibodies. So anti-nuclear antibodies is actually antibodies directed against antigen in cell nuclei. So more than 95% of patients with lupus may have anti-nuclear antibodies, and it is performed most commonly performed using immunofluorescent, indirect immunofluorescent assay. So the most specific ANA or anti-nuclear antibodies for SLE is the anti-double-stranded DNA, because this one is lupus specific. Okay, and if you will be looking at the table of your book, particularly in table 18.2, you would notice that there are some immunologic patterns that we can actually determine what antibodies are actually present. So anyway, let's enumerate some of the antibodies. We also have the anti-single-stranded DNA, anti-histones and nucleosomes, antibodies to centromere or nucleolar components, and then we also have the anti-extractable nuclear antigens. So this includes your anti-SM, anti-RNP, anti-SSA, and anti-SSB. Okay, so as what I've told you, the principle of anti-nuclear antibodies assay would be by means of indirect immunofluorescent assay. So as you can see here, the known antigen, okay, is placed here in the slide, and then we add patient's antibodies. If patient's antibodies are present specific to the antigen, it will be attached here, so they will form an immune complex, and then we add a fluorescent labeled anti-human globulin, which will attach to the Fc portion of the patient's antibody. And then we look under the microscope to determine what would be the pattern. So what are the possible patterns? Homogeneous, as you can see, the homogeneous, it's plain. Okay, it's plain. And then the rim, because they're in the rim, only the sides would have the fluorescent. And then we have the speckled, okay, nucleolar, and then the centromere. So anti-double-stranded DNA, the antigen here is the double-stranded DNA, and it is the one that is most specific for SLE. So the pattern of anti-double-stranded DNA, as shown in page 241 of your book, is said to be peripheral. So here's the peripheral or homogeneous. Peripheral is also known as rim, okay? And then anti-single-stranded DNA is not detected on routine screening. Okay? And then we also have the anti-histone. It is also homogeneous and usually for drug-induced SLE. Okay? And anti-DNP is also homogeneous for SLE and drug-induced SLE as well. The anti-SM and anti-RNP are coarse speckled. So that's how they describe it. Coarse speckled. Okay? So anti-SM is also diagnostic for SLE. Anti-RNP is not really specific for SLE because other autoimmune diseases such as the mixed connective tissue disease, MCTD, may also yield a positive result for this. And then there are two types of anti-SS, okay? Anti-SS could be anti-SSA or SSB. So they are finely speckled and it is not specific for SLE because other autoimmune disease such as Sjogren's syndrome. So you know Sjogren's syndrome is a type of autoimmune disease wherein the lacrimal gland is affected. So there would be dry eyes and dry mouth. Okay, Sjogren's syndrome. And then anti-nucleolar. The immunofluorescent pattern is that prominent staining of nucleoli. So such as here, the nucleolar. Anti-nucleolar is not also specific for SLE. Aside from SLE, systemic sclerosis may also yield a positive result for anti-nucleolar. And then anti-SCL70, the antigen here is quite unique. It's DNA topoisomerase 1, isomerase 1. So it is an atypical speckled, and it is for systemic sclerosis and scleroderma. Anti-Jo1, the antigen here is histidyl tRNA synthetase. Okay, and the homogeneous, the immunofluorescent pattern is atypical speckled, and it is used for the diagnosis, or it is the disease that is associated with this is the systemic sclerosis and or scleroderma. Anti-Jo1 pala is polymyositis. I stand corrected for that. Okay. Now the autoantibody anti-centromere, the antigen is antigen is the chromosome centromere. So the immunofluorescent pattern here is discrete speckled. and it is actually associated with the CREST syndrome. Okay, so these are the different homogeneous immunofluorescent patterns and the disease association with the fluorescent ANA. Okay, so some of them, aside from using the conventional type of indirect immunofluorescent, there's a particular protozoans that may utilize to diagnose SLE. This is the Crithidia luciliae, so it's a type of flagellates. Okay, so this may serve as the flagellate because here it contains this particular type of protozoan contains circular organelle called kinetoplast. So this is where the flagellum is attached. Okay, and this kinetoplast is said to be rich in DNA. So it is used to detect antibodies to double-stranded DNA. Okay, then Ouchterlony or double immunodiffusion may also used to detect antibodies against specific extractable nuclear antigen or the ENA. So the patient serum or the control well, okay, patient serum or controls are found in the outer well. So these are the outer wells and it reacts with ENA. So the extractable nuclear antigen is supposed to be found here in the middle or in the center well. So in this example, patient A has antibody to SM, anti-SM. Why? Because as you can see here in the illustration, there is a semi-arc formation. Okay. So aside from the utilization of anti-nuclear antibodies, we can also use phospholipid antibodies. So these phospholipid antibodies are, and the most common example of this one is the lupus anticoagulant. It is found in 60% of patients with lupus. So if you have phospholipid antibodies, this may be associated with deep vein and arterial thrombosis. So phospholipid antibodies, in some cases, in the later, we call it APAS. And people with APAS, particularly females, may be at risk of recurrent pregnancy loss. Okay? And it may also cause false positive result in non-treponemal test for syphilis. And if a person has lupus anticoagulant and whenever we perform coagulation testing, it will result also to prolong activated partial thromboplastin time and prothrombin time. Example of autoimmune disease that mostly affecting females is the rheumatoid arthritis. So rheumatoid arthritis is actually defined as the chronic arthritis of the peripheral joints, and it will progress to joint deformity, and in some severe cases, it may also result to disability. And unfortunately, about 25% of patients with rheumatoid arthritis may develop osteoporosis. And osteoporosis means that the bone of that person becomes very porous. So it means na magiging mahina na yung bone niya. And this particular and majority of patients with rheumatoid arthritis are actually females. So what are the signs of having rheumatoid arthritis? So there would be subcutaneous nodules. Kaya meron kayong makikita sa mga joints na mga bukol-bukol, pericarditis, interstitial lung disease, and even vasculitis. Or when you say vasculitis, it is the inflammation of the blood vessel.
Alright, go.
So, the pathology and treatment for rheumatoid arthritis. Since rheumatoid arthritis involves the inflammation that destroys the bone and cartilage, okay, it is very important to understand that majority of the patients with this particular disease are actually being given non-steroidal anti-inflammatory drugs. However, we have to understand the pathology. The alpha tumor necrosis factor plays a key role in the process. So, what will happen here is that overly active osteoclast are being absorbed into the bone. So what do you mean by osteoclast? Remember in histology, we discussed that there are several types of bone cells. So these are the osteocytes, the osteoblasts, and the osteoclasts. Osteoclast is a type of cell that is involved in bone destruction, meaning the calcium is actually being degraded. So in this particular scenario, autoantibodies will combine with antigen. So antigen plus antibodies will form in the immune complex. And this particular immune complex will be deposited in the synovial joints. Therefore, treatment, as what I've told you, will mostly involve non-steroidal anti-inflammatory drugs. But the purpose of these NSAIDs will just to address the inflammation, will just to alleviate the pain. It will not totally cause, or it will not totally result to treatment. So perhaps some doctors will actually prescribe disease-modifying anti-rheumatic drugs and biologic agents that will specifically target cytokines such as alpha tumor necrosis factor. Okay? So, in the laboratory, we can help physician diagnose rheumatoid arthritis by measuring the rheumatoid factor. However, I'd like to emphasize here is that rheumatoid factor is not really specific for rheumatoid arthritis. So, rheumatoid factor is actually an assay for us to determine the presence of an autoantibody. Most of these antibodies are IgM by nature, and rheumatoid factor, the autoantibody reacts with the Fc portion of IgG, which is actually not normal. Okay? Rheumatoid factor is found approximately in 80% of patients with RA. And like what I've told you, rheumatoid factor may not necessarily be specific for rheumatoid arthritis. Okay? And then, anti-CCP or the cyclic citrullinated peptide. So a peptide containing a modified arginine. This one is much better because it is more highly specific for rheumatoid arthritis as compared to rheumatoid factor. Although in the laboratory, rheumatoid factor is much easier to perform. So we can also utilize ANA, but ANA is actually more specific for systemic lupus erythematosus such as the anti-DS DNA. Other tests may be supplemental, such as ESR and CRP to assess the level of inflammation, and of course, the assay for complement component, such as C3. Now remember, generally speaking, complement, such as C3, is decreased in cases of autoimmune diseases. Okay, so another example of autoimmune disease is the granulomatosis, let me say that again. Granulomatosis with polyangiitis, otherwise known as the Wegner's granulomatosis. Wow, it's quite challenging to pronounce that, right? This particular type of autoimmune disease is quite difficult to pronounce, yes, and it is also rare, involving inflammation of small to medium-sized blood vessels, so you'd expect vasculitis to be present, and even the respiratory tract. Eventually, this particular type of autoimmune disease will progress to more systemic disease that may involve other organs such as kidneys, joint, and skin. Most patients have antibodies to neutrophil cytoplasmic antigens such as proteinase 3. So, anti-proteinase 3. So, neutrophil activation results in damage to vascular endothelium and a Th1 response. Okay? Therefore, ANCA or the Anti-Neutrophil Cytoplasmic Antibodies may be useful. These are antibodies that we usually produce against proteins in neutrophil granules. So, if you notice, segmenters or neutrophils would have granules in their cytoplasm. So, ANCA is strongly associated with syndromes involving vascular inflammation. So, whenever there is vasculitis, some of the doctors may request in the lab the presence of ANCA, although not all laboratories may be capable of doing such a thing. So, it's because the diagnosis of ANCA may involve the utilization of sophisticated laboratory apparatus such as fluorescent microscope. As you can see here, it is detected by indirect immunofluorescence on ethanol-fixed leukocytes. It can also involve, or we can also use, we can also assay this using enzyme-linked immunosorbent assay or chemiluminescent immunosorbent. Okay, so as you can see, this is the illustration of a cell that has been positive with the ANCA pattern. Okay, so this person may have the Wegner's Granulomatosis. Okay, so let's talk about this time autoimmune diseases directed against thyroid. We call it the autoimmune thyroid diseases. So let's talk about first the synthesis of the thyroid hormone. So thyroid hormone synthesis is carefully regulated by endocrine feedback loop. So as you can see here, the hypothalamus produces TRH, thyrotropin releasing hormone, and it will target the pituitary gland. Okay, and thyroid stimulating hormones are supposed to stimulate the production of thyroid hormones such as the T3 and the T4. Okay, the tetraiodothyronine. Okay, so that's T4. And then the triiodothyronine, so T4 or T3 or T4, or also known, otherwise known as thyroxine. Okay, however, there are some antibodies, autoantibodies, that could either stimulate the TSH to produce more thyroid hormones in cases of Graves' disease. Okay, there are even some autoantibodies that will inhibit the production of more thyroid hormones. Nevertheless, both Hashimoto's and Graves' disease will result into the enlargement of the thyroid gland. Okay, that particular enlargement is commonly known as the goiter. Okay, so goiter may reflect both hyperthyroidism or hypothyroidism. Okay, so let's talk about Hashimoto thyroiditis. So Hashimoto thyroiditis is actually the immune destruction of the thyroid gland. So it will result to hypothyroidism. So in hypothyroidism, there is a normal or high TSH, low free T4, and the presence of anti-TPO and anti-TG. So symptoms include fatigue, dry skin, weight gain, brittle hair, and formation of goiter. So which is the exact opposite of Graves' disease? Because in Graves' disease, it is characterized by hyperthyroidism. So symptoms include nervousness, weight loss, rapid heartbeat, goiter, and exophthalmos. So para yung lumalaki yung mata niya. Okay? And then the thyroglobulin antibodies are also being produced. And then there is also a low TSH, high FT4, and antibodies against TPO and okay. Now, moving on, let's discuss now another example of autoimmune disease. This one, it's about type 1 diabetes mellitus. So, it is an endocrine disorder characterized by hyperglycemia, as we all know. But you might be wondering, how come that diabetes is also considered as an autoimmune disease? Well, the type 1 may be considered as an autoimmune disease because this involves destruction of the beta cells in the pancreas, resulting in insulin deficiency. And as we all know, if insulin is deficient, we'll not be able to control our blood sugar. So long-term effects may include cardiovascular disease, kidney dysfunction, nerve damage, blindness, and even uncontrolled infections. So laboratory results, you have to determine, of course, you have to monitor the blood glucose, level, and then long-term glucose monitoring will include HbA1c, hemoglobin hemoglobin A1c, or hemoglobin A1c, or the glycosylated hemoglobin, and autoantibodies against GAD, IA2, and ECA. So GAD actually refers to glutamic acid decarboxylase, and then IA2 is actually antibodies against the islet tyrosine autoantibodies, and ECA is actually the islet cell antibodies. These antibodies are found actually the pancreas. So whenever these antibodies are actually destroyed, okay, whenever these particular antibodies target the cells, the beta cells of our pancreas, this may result to insulin deficiency. Okay, so we also have celiac disease. It is actually a type of disease that affect our small intestine and other organs. So celiac disease is actually triggered by the presence of gluten in our diet. So what is a gluten? Actually, the term gluten, the Latin term for gluten means to stick. Because gluten is a group of protein, and most of these proteins are found in cereal grains. So these proteins are primarily vitamins and glutenins. So these are the component of the proteins, and it comprises about 75 to 85% of total protein in bread wheat. Okay, so whenever we eat bread, the protein component of majority of these proteins are actually glutens. So aside from wheat, there are several types of wheat that may have glutens. Okay, so this includes barley, rye, okay, emmer, if you're familiar with that one. Okay, so glutens have the so-called viscoelastic and adhesive properties. So that's the reason why they call it gluten. However, in some individuals, glutens can trigger adverse inflammatory, immunologic, and autoimmune reaction in some people. So because they can produce a broad spectrum of disorder, and celiac disease is actually one of them. Okay, so that's the reason why it's very important, if you're a food manufacturer, it's very important that you indicate whether gluten is present or not. Okay, so in celiac disease, autoantibodies are formed against HLA-DQ2, HLA-DQ8. Okay, so if you have autoantibodies formed in HLA-DQ2 or HLA-DQ8, this is actually positive. Okay, and these are actually found in people who are actually sensitive to gluten. For people who are positive with this factor, gliadin, tissue transglutaminase, and endomysium are predisposed to have celiac disease, especially if antibodies are formed against this particular component. So, since you develop autoantibodies against this particular component, you'll not be able to properly absorb nutrients. Okay? Therefore, it may result to diarrhea, abdominal pain, bloating, and others. So the treatment is to follow a gluten-free diet. Okay, so we also have the autoimmune liver diseases, immune-mediated liver diseases that can lead to end-stage liver failure if untreated. So clinical features include elevated liver enzymes, fatigue, nausea, vomiting, abdominal pain, and itchy skin. Elevated liver enzymes, you have to know what are the different types of liver enzymes. So SGOT, SGPT, GGT, for example. Okay, so alkaline phosphatase also. So autoimmune hepatitis, here the hepatocytes are triggered. So a person would For IH1, a person would be positive for SMA and ANA. And for AIH2, that person would be positive for LKM1 and LC1 antibodies. Person who are considered as AIH1 is positive for smooth muscle antibodies and anti-nuclear antibodies. If it's type 2, that person is positive for liver, kidney, microsomal antibodies, and LC refers to the anti-liver cytosol type 1 antibodies. Okay. And then primary biliary cirrhosis is a type of, again, a class of autoimmune liver disease wherein it involves destruction of an intrahepatic bile duct. So there will be cholestasis. So majority of patients will produce mitochondrial antibodies. And then there's another example of autoimmune disease. This is the multiple sclerosis. So this particular type of autoimmune disease involves inflammation and destruction of the central nervous system. So majority of the patient will produce antibodies against myelin basic protein. So the myelin sheath is very important for our nerve fibers because it protects our nerve fibers. Remember the Schwann cells, they are the one that produce the myelin. And then the myelin will allow smooth conduction of nerve impulse. Now, if the nerve impulse is if the myelin is actually destroyed, there won't be any smooth transmission of the impulse. Okay? How would you know if the myelin sheath are destroyed? It is characterized by the presence of plaques formed in white matter of brain and spinal cord, causing destruction of myelin sheath of axons. So since the nerve impulse transmission is not smooth, symptoms would include visual disturbances, weakness in limbs, dizziness, and sensory abnormalities. So, laboratory finding includes lesion seen on magnetic resonance imaging. So, magpapa-MRI yung patient. Increase in immunoglobulins in CSF, particularly the IgG index, and the presence of oligoclonal bands on protein electrophoresis of CSF. So, another example of autoimmune disease is the myasthenia gravis. So, this time, myasthenia gravis affects the neuromuscular junction. So, in the neuromuscular junction, this is, for example, the acetylcholine, and then this is the acetylcholine receptor. Neurotransmitter acetylcholine is important so that we'll have skeletal muscle contraction. However, if you produce antibodies against the receptor sites will be blocked. And if there is a blocking of the receptor site, then there won't be the skeletal muscle contraction will be affected because you block the binding of acetylcholine to its receptor, and transmission of nerve impulse that activate the muscles will be affected. So what will happen is that there would be paralysis and eventually weak skeletal muscles and eventually paralysis. Good pasture syndrome is a type of autoimmune disease wherein the patient produces autoantibodies to basement membrane. Okay? In lining in the renal glomeruli and lung alveoli. So immune complex will be deposited in the kidneys and also in the lung alveoli, specifically directed against the alpha-3 chain of type 4 collagen. So this immune complex will eventually attract, complement, and cause damage by type 2 hypersensitivity reaction. If you remember our discussion on type 2 is an example of cytotoxic or cytolysis. Okay? Syndromes may progress to renal failure if it's the basement membrane of the kidneys, or respiratory problems if the immune complex are actually deposited in lung alveoli. So, if it's in the kidneys, renal failure will happen. If it's in the lung alveoli, respiratory problems such as coughing, shortness of breath, and hemoptysis or coughing out of blood will occur. So, Here, patients with good pasture syndrome will develop antibodies to the GBM, okay, in the basement membrane. So we call it the anti-GBM. So this is detected by indirect immunofluorescent frozen kidney sections, or we can also do ELISA for antibody to alpha-3 subunit. So the tissue-bound anti-GBM detected by direct immunofluorescence on kidney biopsy section is one way of diagnosing it. So usually there would be the pattern under the fluorescent microscope is said to be smooth, linear, ribbon-like fluorescence along the GBM. GBM refers to good pasture basement membrane antigen. So if you develop antibodies against GBM, then most likely you develop also an autoimmune disease known as the good pasture syndrome. So do not forget that in good pasture syndrome, both of your kidneys and lungs are affected. Okay, so there you have it. That's the end of our discussion for the autoimmune disease. Do not forget to study your lesson. God bless everyone. Bye.